Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Professor Nicole Concin from the Medical University in Innsbruck, Austria, in the Kliniken Essen-Mitte in Essen, Germany. She will be highlighting new clinical trial data for endometrial and ovarian cancers presented at the 2021 ESGO annual meeting. This episode is part of a larger educational program entitled 2021 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on Professor Concin, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear Professor Concin's thoughts on some clinically important findings presented at the 2021 ESGO annual meeting.
My name is Nicole Concin. I'm a gynecological oncologist and professor at the Department of Gynaecology and Obstetrics at the Medical University of Innsbruck in Austria and also at the Kliniken Essen-Mitte in Essen, Germany, which is an ESGO accredited center for excellence in ovarian cancer surgery. Today, we will highlight some of the key studies that were presented at ESGO 2021 in Prague, focusing on key data for ovarian and for endometrial cancer. And the first study that I would like to highlight is actually a study coming from our center, the Kliniken Essen-Mitte in Essen, Germany, and was presented by Florian Heitz from the Andreas Dubois group in Essen in an HGO Germany cooperation with ENGOT group. They evaluated the surgical outcome as prognostic factor in different histological subtypes of ovarian cancer, and as a database, the HGO mega database was used, which included 7 prospective randomized upfront phase 3 trials, multi-center trials in which explorative analysis have been performed for surgical outcome related to different histological subtypes. So what were the results for high-grade serous ovarian carcinoma? The longest median overall survival of 68 months was seen in the patients with complete macroscopic resection during upfront debulking surgery. Patients with small residual disease, meaning less than 1 centimeter, had a median overall survival of about 37 months, and with gross residual disease more than 1 centimeter, median overall survival was around 33 months. The differences between these residual disease groups were statistically significant in this high-grade serous histological subtype, meaning that also patients with small residual disease had a certain benefit of the surgery, while of course the strongest benefit was seen if complete macroscopic resection could be achieved. So how was this in the low-grade serous group? Here also, patients whom complete macroscopic resection to no residual disease was achieved had the highest overall survival with a median of 111 months versus 70 months with small residual disease and 40 months with gross residual disease. Importantly, there was no statistically significant difference between small and gross volume disease, but the numbers showed a strong difference, 40 versus 70 months, but not statistically significant. This might be due to the case numbers. Maybe the numbers were too small to show a significant difference in this group of low-grade serous carcinomas. For the mucinous group, also complete macroscopic resection, clearly the best median overall survival with 35 months compared to small and gross residual disease. Both had around 14 months, so no difference in median overall survival in small and gross residual disease. So clearly only patients with complete macroscopic resection derived a benefit from the surgery. And last, the clear cell carcinoma cohort. One has to point out that this was the smallest group with only 71 patients in this study, and there was best median overall survival as expected with complete macroscopic resection. For the other group, small and gross residual disease, one cannot really draw robust conclusions because of the small case number. So what does this mean, this study for us? What is the bottom line message and what is the clinical relevance of these data? This study has shown that clearly upfront debulking surgery with complete macroscopic resection remains the best prognostic factor in advanced epithelial ovarian cancer among the histological subtypes. If you compare them with any residual disease, the best benefit is achieved with complete macroscopic resection, and thus primary debulking surgery should be offered to all advanced stage ovarian cancer patients in whom we consider that complete macroscopic resection can be achieved with acceptable morbidity. For the group of high-grade carcinomas, this was the only group where a statistically significant difference in median overall survival could be shown between the group small residual disease, less than 1 centimeter, and gross residual disease, more than 1 centimeter, meaning that in these patients, if you can not achieve complete macroscopic resection, that also if you can achieve small residual disease, this will add moderate benefit to these patients. So even small residual disease result of primary debulking surgery is a benefit for high-grade serous ovarian cancer patients. Also in the low-grade tumors, we saw that small residual disease had substantially better overall median survival compared to gross residual disease, but was not statistically significant. How does these findings now implement our clinical practice? First, the triage of patients at primary diagnosis. If you go for primary debulking surgery, or if you go for neoadjuvant chemotherapy, followed by potentially interval debulking surgery. So in patients where you think you can achieve complete macroscopic resection, you for sure go for primary debulking surgery. This is the standard of care, followed by platinum-based adjuvant treatment. It also has an important impact on your intraoperative management of patients, and I will give you an example on this. For example, if you do primary debulking surgery in a high-grade serous ovarian carcinoma patient, and this patient, let's say, has a lot of comorbidities, this is a frail patient, and you realize intraoperatively that you would need very radical surgical approach in order to achieve complete macroscopic resection. For example, you would need a complete colectomy in these patients. Then you would risk in this frail patient that this patient will not recover after surgery, will have a lot of complications, potentially die from complications. So in a high-grade serous ovarian cancer patient like this, you would aim for an adapted radicality approach, less radical approach, and would be satisfied with small residual disease in this patient because you still know this patient has a benefit from your primary debulking surgery approach. But if this is a patient with mucinous disease, you know only complete Microscopic resection will have a benefit for this patient. Thus, you will not go for minimal residual disease. You will simply stop the surgery, close the abdomen, because you know you will only add morbidity from the surgery to this patient, but the patient will not have a benefit from your radical approach. So for the mucinous ovarian carcinoma patient advanced stage, the prognosis is in general bad prognosis. PARP inhibitor maintenance treatment is only approved for high-grade epithelial ovarian cancer disease, and bevacizumab is approved for advanced stage epithelial. So bevacizumab is an option in this patient to be added to the chemotherapy, but the response rates of the mucinous tumor to platinum-based chemotherapy and bevacizumab is unfortunately not very promising. So the next two studies that I'm going to highlight are both in endometrial carcinoma patients. The first one is the GARNET trial, which is actually a phase 1 single-arm trial evaluating dostarlimab monotherapy in multiple tumor types, dostarlimab being an anti-PD-1 monoclonal antibody. And this study also included 2 cohorts of endometrial carcinoma patients as expansion cohorts, the A1 cohort in mismatch repair deficient microsatellite instability high patients, and the A2 cohort in mismatch repair proficient patients. The patients must have had 2 or less prior chemotherapy lines. The safety population in the mismatch repair deficient group included around 129 patients, and in the proficient group, 161 patients were included. The primary endpoint was objective response rate, and here we saw in the mismatch repair deficient group a compelling overall response rate of 43.5%, and in the mismatch repair proficient group, response rate of 14.1%. With dostarlimab, we see treatment-related adverse events, which mainly comprise of fatigue, diarrhea, nausea, asthenia. It's in general well-tolerated and low-grade toxicity. High-grade toxicity, grade 3 and higher, is seen in approximately 16% of patients. This study actually has led to the approval of dostarlimab in Europe. This was end of April, and this was a big change in our treatment of relapsed endometrial carcinoma patients, because now with dostarlimab being approved for recurrent and advanced stage mismatch repair deficient patients that have progressed after prior platinum-based treatment, we have a good treatment option for our patients. Very recently in Europe, we have now also the approval of pembrolizumab in combination with lenvatinib, so another PD-1 inhibitor in combination with an oral tyrosine kinase inhibitor, which has an anti-angiogenetic effect. It's approved in the same indication, but for all comers, so independent of mismatch repair status. So it's very clear in the GARNET trial that the highest benefit of dostarlimab is achieved in the mismatch repair deficient group, the MSI high group or mismatch repair deficient group. So mismatch repair deficiency is really the biomarker for response to single agent immune therapy. this can be considered the biomarker for response. So the highest benefit of single agent IO, we know this also from various different IO studies, not only from the GARNET trial. These are the patients that really benefit most from immune therapy single agent treatment. And this is why it is also so important to perform molecular testing in our endometrial carcinoma patients in order to identify the patients that benefit most. So the knowledge on molecular marker profile will influence our treatment decision. So these are really very exciting times that we now have the option of IO treatment in relapsed endometrial carcinoma patients. The second trial I want to highlight in endometrial carcinoma is the TOTEM trial, which has evaluated different strategies of follow-up in all stages endometrial carcinoma patients with no residual macroscopic disease after surgery. And the patients were divided into low-risk group and high-risk group, and both groups were randomized to either receive an intensive follow-up or a minimalist follow-up. The minimalist follow-up in the low-risk group included clinical examination only, while the intensive follow-up in the low-risk group also included yearly pap smears and a CT scan at the end of the first and the second year. And in the high-risk group, the minimalist follow-up was clinical examination only plus a CT scan at the end of the first and the second year, and the intensified schedule was CA 125 measurements in addition to clinical examination, pap smears yearly, and ultrasound every 6 months, and CT scans on a yearly basis. Importantly, this trial has not shown any overall survival difference, no matter if you apply intensive follow-up or minimalistic follow-up in both of the risk groups. Also, no difference in relapse-free survival, and importantly, no difference in quality of life comparing these two follow-up strategies. But the costs of the follow-up were significantly higher in the intensified approach. So this trial clearly showed for our clinical practice that it does not make any sense and does not improve survival of our patients if we intensify the follow-up strategy, particularly routinely no pap smears, no CA 125 measurements, and no routine CT scans should be performed. This is the first time that we have data from a randomized prospective trial, so the author should really be applauded to have performed such a trial. What one might need to take into consideration is that the risk group allocation in this trial can be criticized. The low risk group was defined as 1A, grade 1 and 2 patients, which indeed in general considered low risk group if you consider clinical pathological parameters only. But the high risk group was defined as stage 1A with grade 3 or patients higher or equal 1B stage. So this is actually a very heterogeneous group of patients. If we look at the newly published triple European guidelines on endometrial carcinoma management, which were jointly developed by the ESGO, the European Gynaecologist, the ESTRO, the European Radiation Oncologist, and the ESP, the European Pathologist, so 3 societies, if you just look at the risk group allocation based on clinical pathological parameters, then the risk group high risk, like defined in the TOTEM trial, would also include patients that we allocate to intermediate risk group and to high intermediate risk group. So this would not only be high risk patients like considered here in the TOTEM trial. So lymph vascular space involvement, for example, was not respected from clinical pathological parameters. And now in the era of molecular characterization of endometrial carcinoma and integration of molecular markers into risk group stratification, of course, also the molecular marker profile was not respected in the TOTEM trial.
Thank you very much, Professor Concin, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2021 global conference coverage, and update on the clinical development across gynecologic malignancies, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.